Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of January 2007. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. We'll begin with a report on the cost of treatment for adolescents with mental illness by Jane Costello and colleagues. This will be followed by a group of articles on addiction, impulsivity, and risk-taking. These reports are linked together in an editorial by Mark Potenza entitled To Do or Not to Do, The Complexities of Addiction, Motivation, Self-Control, and Impulsivity. Then we'll turn to this month's clinical case conference by Peter Fried and John Mann. The title is Sadness and Loss, Toward a Neurobiopsychosocial Model. The next group of featured articles report on cognitive behavior therapy for specific conditions. These include co-occurring bipolar disorder and substance dependence, hypochondriasis, and post-traumatic stress disorder. The final article we'll highlight addresses eating disorders. The article is entitled Perceived Coercion and Change in Perceived Need for Admission in Patients Hospitalized for Eating Disorders. The authors are Angela Guarda and colleagues. We will also cover the related editorial by Arnold Anderson. Let's begin with the article by Jane Costello and colleagues entitled Service Costs of Caring for Adolescents with Mental Illness in a Rural Community, 1993 through 2000. Previous estimates of the cost of treating mental illness in adolescents have not included care provided in non-medical settings, such as schools, juvenile justice settings, and social service agencies. The investigators in this study assessed 21 types of mental health services. The study covered an 11-county area in North Carolina, where the mental health care system was considered adequate. A representative sample of students were selected for a large population-based study. 1/3 were 9 years old, another third were 11, and the other third were 13 years old. The students were interviewed every year, and psychiatric diagnoses were based on these interviews. The need for mental health services was defined as either a psychiatric diagnosis or symptoms that impaired functioning. Data on the services actually received were collected for 1,400 of these students when they reached ages 13 to 16. Estimates of the cost of each type of service were obtained from a range of national, state, and local sources. 18% of the adolescents had used mental health services in the preceding 3 months. However, of the youth who were deemed to need them, 2/3 had not received mental health services of any type. Only about 7% of the total mental health costs for these adolescents was for outpatient services by mental health specialists. Juvenile justice and inpatient facilities accounted for 67% of all costs. Schools were the most frequent service providers, but were responsible for only 13% of the costs. These findings on juvenile justice and school services demonstrate that the costs of treatment for the mental health problems of adolescents are commonly borne by agencies that were not designed primarily to provide psychiatric or psychological services. Next, we'll turn to the articles on impulse control. First, we'll highlight an article by Elliott Hong and colleagues entitled Independent Domains of Inhibitory Gating in Schizophrenia and the Effect of Stimulus Interval. Failure of inhibitory mechanisms has been implicated in several psychiatric illnesses. Patients with schizophrenia typically are unable to suppress physiologic reactions to predictable auditory clicks and tones. This study demonstrated that this lack of normal inhibition may reflect more than one dysfunctional process. The investigators used 2 common measures of the brain's ability to inhibit a reaction, the startle response and the P50 component of the EEG. Previous studies have shown a general lack of correlation between these two measures in healthy subjects, but the correlation in patients with schizophrenia has not been examined, even though many of these patients have such abnormalities. In this study, a group of patients with schizophrenia showed deficits in both measures of physiologic inhibition compared to healthy subjects. However, the two abnormalities were not correlated within the patients. Many individuals had only one or the other deficit, not both. Therefore, the two measures may mark independent aspects of abnormal brain inhibitory function in schizophrenia. The next article in this series is entitled Neural Circuitry Engaged During Unsuccessful Motor Inhibition in Pediatric Bipolar Disorder by Ellen Liebenluft and colleagues. In this study, the researchers administered a task that tested the ability to inhibit a motor response. The test was given to children with bipolar disorder and to a comparison group of children. The investigators examined the children's brain activity during only the tests when the motor response could not be inhibited. During these failed inhibitory trials, the comparison subjects showed greater activation of the right ventral prefrontal cortex and the bilateral striatum than the children with bipolar disorder. The underactivation in the children with bipolar disorder could indicate an inability to engage these brain regions. Impaired impulse control among adolescents is examined in the next article on risk-taking behaviors among Israeli adolescents exposed to recurrent terrorism. The authors are Ruth Pathorinchik and colleagues. The study participants were 400 Israeli adolescents ages 15 to 18 years. More than 70% had had personal exposure to terrorist attacks or near misses. Many also reported taking risks in the preceding month. The rates varied from 9% for Russian roulette to 69% for disobedience in school. Greater risk-taking was associated with greater exposure to terrorism and with more symptoms of post-traumatic stress disorder. Boys reported taking more risks than girls, and the association between post-traumatic symptoms and risk-taking was stronger for boys than for girls. The high frequency overall indicates that risk-taking behaviors should be routinely assessed in youth with PTSD. It also suggests that these behaviors may signal emotional distress in adolescents exposed to terrorism. Drug dependence is the focus of the next article, which addresses whether decreased prefrontal cortical sensitivity to monetary reward is associated with impaired motivation and self-control in cocaine addiction. The authors are Rita Goldstein and colleagues. Addiction has been associated with an impaired ability to inhibit responses and with excessive attribution of salience to drugs. This article focuses on neurobiological markers of motivation and the response to non-drug rewards in people with cocaine addiction. Cocaine abusers and healthy subjects were given monetary rewards for correct performance on a task involving responses to specified stimuli. Since the cognitive aspects of reward anticipation seem to involve the lateral prefrontal cortex, activity in the prefrontal cortex and subcortical regions was measured during the task. The brain responses of cocaine abusers and healthy subjects were compared. The study also examined how different amounts of money affected the brain response. The healthy subjects had a complex pattern of brain responses, but the subjects addicted to cocaine had less robust responses and less sensitivity to differences between monetary values. Also, for the comparison subjects, faster and more accurate responses to the largest amount of money were associated with a greater engagement in the task. In contrast, the cocaine abusers' reports of engagement were disconnected from their actual performance. The editorial by Mark Potenza links the preceding 4 articles. The editorial is entitled, "To Do or Not to Do: The Complexities of Addiction, Motivation, Self-Control, and Impulsivity." The editorial begins with the Goldstein study of subjects with cocaine abuse. Since addictions involve continuation of a behavior despite adverse consequences, they have been viewed as disorders of misdirected motivation and impaired self-control. Addicted individuals tend to select small, immediate rewards over larger, delayed rewards. This tendency has important clinical implications given that risky, disadvantageous, or impulsive decision-making has been correlated with adverse measures of real-life functioning in addicted groups and in those at risk for addiction, such as adolescents. Moreover, treatments that provide small, immediate rewards for abstinence, such as contingency management, have demonstrated efficacy in the short-term treatment of addiction, thus identifying differences in the neural processing of monetary rewards by cocaine-abusing subjects, and the relationship of these differences to self-control and motivation lays important groundwork for improving prevention and treatment. The Goldstein article has important implications extending beyond addictions. Impulsivity is relevant to many psychiatric disorders and has been defined as a predisposition toward rapid, unplanned reactions to internal or external stimuli with diminished regard for negative consequences. This definition not only overlaps with ones for addiction, but also indicates that impulsivity is complex and multifaceted. Hence, understanding how specific elements of impulsivity, such as response inhibition, relate to specific psychiatric disorders should help optimize prevention and treatment for not only addictions, but also other mental health disorders. The articles by Hong, Liebenluft, and Pat Horenchek highlight the complexity of impulse regulation and its relevance across diagnostic boundaries. The Hong study demonstrates that 2 measures of sensory gating in schizophrenia are inversely or largely unrelated, suggesting that there exist multiple independent components of inhibitory function in schizophrenia. These findings echo those in the Goldstein article, in which 2 measures related to impulsivity, reaction time, and subject-reported self-control were inversely correlated among cocaine-abusing subjects, but not subjects without addictions. The Liebenluft article reports neural correlates of unsuccessful motor inhibition in children with bipolar disorder, in medicated and unmedicated states, and with and without attention deficit hyperactivity disorder. Because bipolar disorder and ADHD are each characterized by impaired impulse control and are treated with medications that diminish impulsive behaviors, dissecting the relative contributions of co-occurrence and pharmacotherapy is not only important in understanding the neuroimaging findings, but also clinically relevant. The Pat Horenchek study examined the relationship between terrorism exposure and risk-taking behaviors. The findings highlight sex differences in the relationship between environmental risk factors and behaviors characterized by impaired impulse control. Boys showed a stronger correlation than girls between post-traumatic symptoms and risk-taking. Together, these 4 studies reinforce the notion that impulsivity and related constructs not only are relevant to multiple psychiatric disorders, but also are complex phenomena influenced by multiple environmental and biologic factors. This concludes the highlights of the editorial by Mark Potenza. Please refer to the January issue for the full editorial and the articles it discusses. Now we'll turn to this month's clinical case conference by Peter Fried and John Mann. The title is Sadness and Loss: Toward a Neurobiopsychosocial Model. The article begins with a case report. A 25-year-old female graduate student entered twice-weekly psychodynamic psychotherapy with a stated goal of ending an abusive romantic relationship with a colleague. In the early months, the therapy sessions were filled with the patient's childhood memories of emotional mistreatment by her parents, whose constant fighting left her feeling abandoned and terrified. She contrasted these memories with loving memories of her grandmother. In the 4th month of treatment, the patient's grandmother unexpectedly became ill and died. The patient then entered a period of grief. Subsequent therapy sessions followed a pattern. The patient would arrive in a euthymic state and begin to talk about her grandmother. The therapist responded with supportive clarification and mirroring, using phrases such as, "You really loved her." Sometimes the patient would blurt out, "I cannot believe she's dead," followed by crying of varying intensity, lasting 3 to 10 minutes. Further empathic comments by the therapist prolonged these episodes, but typically the therapist would attend silently. After several minutes, the patient would re-engage, resume eye contact, and talk about how lonely the world was without her grandmother. To this, the therapist typically responded with reflective statements, such as, "It feels that you will not ever be known in that kind of warm way again," which often led the patient to more muted episodes of tearfulness or to the somewhat comforting idea that her grandmother's spirit was watching over her. By session's end, the patient was no longer tearful. She reported having many similar episodes outside of therapy. Over a 3-month period, the frequency and intensity of these episodes decreased. By the 4th month, she discussed her grandmother only occasionally. Despite their clinical frequency, these episodes of intense sadness are rarely studied and poorly understood. Psychiatry's familiarity with major depression and bereavement, both of which feature sadness, leads to the false impression that episodes of sadness lasting several minutes are understood scientifically. In fact, compared with our knowledge of the neurobiology and adaptive function of other brief, intense, normal emotions such as anger and anxiety, our understanding of sadness remains rudimentary. What is the function of sadness? This question has yet to be answered, and it raises 4 further questions that have clinical implications. First, does sad emotion, like anxiety or anger, provide an adaptive benefit, such as actively assisting the process of grief? Second, if sadness is adaptive, what are the psychological and neurobiological mechanisms of action? In particular, does it increase or decrease yearning for the deceased? Third, can sadness in bereavement give way to depressed mood and major depression? If so, is the clinician advised to suppress sadness? Or is sadness a cathartic aspect of grief that the clinician should encourage? Fourth, do normal sadness and major depression lie along a continuum, and is major depression a sadness disorder? In the case presented, the therapist faced each of these questions and grappled with a clinical choice: to encourage the patient's sadness episodes to arise and unfold without interruption, or to use medications or cognitive reframing to suppress them. In choosing the former, he demonstrated adherence to the detachment model of sadness, in which sad emotion is believed to play a useful role in accepting and thereby recovering from loss. However, an alternative model suggests that sadness is designed to promote reunion, not detachment. According to this model, the psychiatrist in the case presented may have inadvertently prolonged the patient's grief by encouraging sadness, thereby placing her at risk of developing complicated bereavement or major depression. Doctors Fried and Mann present psychological, neurobiological, and brain circuitry findings related to sadness, and they emphasize that the lack of integration of these data reflects the absence of a common theoretical model for testing rival theories of sadness. They propose that sadness may be interpreted as a mechanism for altering the incentive salience of cues related to the deceased. They also propose ways of experimentally testing hypothesized models of loss and the role of sadness in grief resolution. They then apply these models to the case presented. Next, we'll highlight 3 studies on cognitive behavior therapy that targeted specific patient populations: those with existing bipolar disorder and substance dependence, those with hypochondriasis, and those who are experiencing post-traumatic stress disorder within 3 months of a traumatic event. The first of these articles is by Robert Weiss and colleagues. The title is A Randomized Trial of Integrated Group Therapy versus Group Drug Counseling for Patients with Bipolar Disorder and Substance Dependence. The integrated group therapy consisted of a 1-hour-long meeting every week for 5 months. It employed a cognitive behavior relapse prevention model that focused on similarities between recovery and relapse processes in bipolar disorder and substance use disorder. The group drug counseling also consisted of 20 weekly sessions, each focusing on a specific topic. The findings could be viewed as paradoxical. Although the integrated therapy focused on mood, the major difference in outcome between the treatments was for substance abuse. The patients receiving integrated treatment based on cognitive behavior therapy had greater reductions in alcohol use than the patients receiving drug counseling. The 2 groups were similar in the number of weeks they were ill with bipolar disorder. The study of hypochondriasis by Anja Greven and colleagues was a comparison of psychotherapy, drug treatment, and placebo. The title is Cognitive Behavior Therapy and Paroxetine in the Treatment of Hypochondriasis, a Randomized Controlled Trial. More than 100 patients participated in the study, which lasted 16 weeks. The rates of response were 45% for cognitive behavior therapy, 30% for paroxetine, and 14% for placebo. Cognitive behavior therapy and paroxetine also reduced symptoms of anxiety, depression, and somatoform disorders. The presence of a coexisting disorder did not predict whether a patient would respond to treatment. The third article on cognitive behavior therapy is Treatment of Acute Post-Traumatic Stress Disorder with Brief Cognitive Behavioral Therapy, a Randomized Controlled Trial by Marit Sabrandi and colleagues. The study included 143 people who had experienced a traumatic incident within the preceding 3 months. The treatment group received 4 weekly sessions of cognitive behavior therapy, each lasting approximately 2 hours. The sessions included deep muscle relaxation exercises, the patient's recounting of the traumatic experience in the present tense, and restructuring of cognitive distortions. Homework included relaxation exercises and confrontation of avoided but safe situations. Follow-up assessments were conducted 1 week after the end of treatment and 4 months after treatment. Patients in the comparison group did not receive the intervention but were assessed at the same intervals. The follow-up evaluations revealed decreases in symptoms of PTSD, anxiety, and depression among both groups. 1 week after treatment, the intervention group had significantly fewer post-traumatic symptoms than the comparison group, but this difference was no longer significant at 4 months. Similar results were found for anxiety and depression scores. Subgroup analyses showed that among patients who had coexisting major depression, those who received cognitive behavior therapy had significantly lower PTSD scores at 4 months than the comparison subjects. Also, among patients whose traumatic incidents were the most recent within the preceding month, the treatment group had lower scores than the comparison group at both 1 week and 4 months. The final article we'll present is Perceived Coercion and Change in Perceived Need for Admission in Patients Hospitalized for Eating Disorders by Angela Guarda and colleagues. The authors begin by pointing out that many patients with severe anorexia nervosa require inpatient treatment, and that hospitalization often occurs after some degree of pressure by clinicians, family, friends, employers, or teachers. The study examined the perception of 139 patients hospitalized for eating disorders in regard to the need for admission. Their opinions were recorded at the time of hospitalization and again 2 weeks later. When they were hospitalized, 1/3 of the patients disagreed with the decision for admission. Of these 46 patients, 20 agreed with the decision 2 weeks later. However, their perceptions of coercion, pressure, and procedural justice did not change over time. There were diagnostic and age-related differences in the findings. Patients with anorexia nervosa perceived greater coercion, greater pressure to be admitted, and less procedural justice than patients with bulimia nervosa. And adolescents were less likely to change their minds and perceived greater coercion compared to adults. The authors advise that care must be taken to avoid an arrogant approach and assume that all patients should be treated equally. Efforts must be made to maintain a positive therapeutic stance at all times. Coercive pressure is justified only by the likelihood that treatment will be beneficial. This likelihood should be assessed on a case-by-case basis. It may be higher for a chronically ill patient who has constantly evaded treatment than for the professional patient with whom numerous admissions, treatment modalities, and attempts at refeeding have failed. This article is accompanied by an editorial by Arnold Anderson entitled Eating Disorders and Coercion. Dr. Anderson states that the study of how ethical principles apply to eating disorders, especially anorexia nervosa, has been neglected. Life-saving commitment to the hospital for major depression with clear suicidal intent and means, or for schizophrenia with command hallucinations, is accepted. Why are eating disorders, especially anorexia nervosa, viewed differently and through a more conflicted lens? There may be several reasons. First, there is no consensus on the core psychopathology of eating disorders. Second, many outdated assumptions and mistruths exist about eating disorders, including the belief that these disorders are voluntary. The core psychopathology of eating disorders is not, as has been intermittently proposed, a psychosis, obsessive-compulsive disorder, or a form fruste of affective disorder. Rather, central to the disorder are overvalued beliefs about the benefits of and need for weight loss or shape change, which led to dieting behavior, binge eating and purging, and severe overexercise. Bulimia nervosa may be viewed as an attempt at anorexia nervosa in individuals who do not have the extreme perseverance that allows some to override the hunger-induced drive to eat. This view suggests a core shared psychopathology for all eating disorders, and, in the persuasive view of some, a transdiagnostic approach to treatment. If a patient's clinical condition meets common legal criteria for petition for involuntary hospitalization and treatment, there is no reason that the category of eating disorders should be excluded from consideration for life-saving treatment. The common criteria for involuntary care are that a patient has a psychiatric disorder, the disorder presents a substantial possibility of a deadly outcome by direct action or inaction by the patient, and the patient does not recognize the need for treatment, even though the illness is life-threatening. Involuntary care can be compassionate care. Although accounts remain sparse in the literature, several recent publications have reported that anorexia nervosa patients who are treated involuntarily do as well in acute treatment as voluntary patients. Within several weeks of the start of treatment, the egosyntonic nature of the eating disorder diminishes, yielding to the patient's recognition of the need for treatment and autonomous support of treatment. By following changes over time in the perception of coerciveness, several goals are accomplished at once. The need for treatment perceived as coercive is validated by the seriousness of the eating disorder. The beneficent use of perceived coercion does not endure long as a perception, but changes to a gradually strengthening therapeutic alliance with the treatment team, and autonomy returns. This concludes the audio highlights of the January issue of the American Journal of Psychiatry. We invite you to refer to the online issue at ajp.psychiatryonline.org for the full text of these and other articles. Thank you.